Hello and welcome to the first in a series of talks aimed at district anesthesia in South Africa. I'm David Bishop and I'll be covering 10 topics on this theme in 2025. This one is the first in the series and is going to look a little at the system and the method for getting district anesthesia right. And then for the rest of the year we'll be diving into specific topics in much more detail. Now, anesthesia in South Africa makes a significant contribution to poor outcomes. Our confidential inquiry from 2017 to 2019 showed that there were 921 deaths over 3 years. Now, 66 of them were directly due to anesthesia. So that's 7%, and that's things like a high spinal or a failed intubation. But a further 139 were indirect anesthetic deaths. And what that means is that's a secondary anesthetic problem. So the death is due to another cause like hemorrhage or hypertension, but action or inaction by the anaesthetist might have contributed significantly to the death or events leading to the death. So 1 in 5 maternal deaths have an anesthetic link in South Africa, where we have enough anaesthetists to do the anesthetics, but the outcomes are poor. We're also not doing enough of the procedures we're supposed to be doing at district level. We're doing mainly Caesars, but not the laparotomies or the long bone fractures that are thought to be appropriate for that setting. They're called the bellwether operations, and that's how you measure whether a district surgical service is reaching the goals. So we are below the standard, both in quantity and in quality, and we need to work out how to get better, and this is what this lecture series is hoping to help you to do. So the first thing that I want to stress is that you're allowed to cheat. This is one of the resources you have, and I'm going to take you through several ways to learn in this talk, as well as pointing out some of the things you must never get wrong as a beginner. But remember that you are allowed to use notes. You're allowed aids in theatre. You're allowed to stick things on the wall. Now, this is an anesthesia module that we are releasing in KwaZulu-Natal, which I'm happy to distribute, which is based on the ESMOE notes, the program that looks at essential steps in the management of obstetric emergencies. And there are a lot of resources within this. We've updated this, and so we've taken the ESMOE label off it. The ESMOE board has been disbanded, and we're not able to update that formally yet. But these are the updates that were done by the ESMOE Anesthetic Committee in written format. Now, one of the first things it tells you is what competencies you're supposed to have at level 1 hospitals, which are district hospitals. And one of the first things you'll notice is that one medical practitioner should have expertise in anesthesia, ideally the diploma in anesthesia. So if you haven't done one and you're thinking about doing one, this is an excellent idea. You need one person in your hospital who is the relative expert. Ideally, you get a few of you together and you find out how to get a DA from the district setting. You can do it. It's hard, but it is possible. So aim to have one person that's taking an extra interest in anesthesia. We call that doctor the lead medical officer in anesthetics. And in KwaZulu-Natal, it's a mandatory that every district hospital appoints someone as the lead anesthetic medical officer, and then that person can be responsible for some of the things I'll talk about today. The second thing I want to highlight is that you are required to provide safe general anesthesia for elective and emergency surgery to adult patients. Now, this is not something that really was even discussed. We are supposed to be getting past spinals and also providing general anesthesia. So if you're listening to this and you think, I can't do a general anesthetic, that should be the goal. And it should be that every single hospital has someone on call every night who is able to assist. So even if the person putting the spinal in is not able to convert to general anesthesia, somebody is able to help them that's on the property and available. So what you want here is a lead anaesthetist. You want a team that's able to do a general anesthetic and a spinal. You need a team that's appropriate for the type of surgery you're doing, and you also need to remember to refer appropriately. We're not aiming to do complex cases in the district setting. And within this document, it tells you what sort of procedures we should be doing. So Caesars, both GA and spinal, these are sort of at fetal distress, poor progress, those sorts of Caesars, elective Caesars that are uncomplicated. But I wanted to highlight there's also these other procedures, postpartum sterilization and mini laparotomy ligation. Now these procedures are they're elective, they're small surgeries, but they come with an anesthetic. And if you're doing these procedures, these are the sorts of cases that are ideal to learn on. So you can bring in your experienced anesthetist, or you can get someone to come on outreach and book a list of these patients, and this is how you practice. So you must look out for these cases. Just below that, I want you to notice that ectopic pregnancies are expected to be done at district level. So a ruptured ectopic pregnancy is not supposed to be referred, and we have to get everyone to the level where they can anesthetize a ruptured ectopic pregnancy. For me, that's the goal. That's the end of the line of where we should be. Now, unfortunately, most of safe medicine involves everyone doing the same thing over and over again. It's boring, I know, but it's effective, and there's really no substitute for this. And someone really needs to know what's in your theatre, where everything is, and check that it's working. Now, ideally, this is the lead anesthetic MO, but everyone should know how to do this. When you need something urgently, it's got to come fast, and it's got to be working when it comes. So, again, you don't have to learn all these things. There's an essential equipment list for anesthesia. This is a copy of it. And if you laminate this and stick it on your wall in your theatres, you'll know what should be in the room. But for me, when I walk into a room when I haven't been the one checking the theatre, there are 3 things I always check, even in my own theatre that I've checked already. Is there a working ambubag? And you must test that it's working by occluding the mask and squeezing the bag. Make sure you can generate a pressure. If the machine fails, this is what saves the life. Oxygen, it's hard to do a general anesthetic without it. Most of the district hospitals run on a cylinder manifold system for oxygen, so the cylinders can run out. Make sure you've got a backup cylinder in theatre. You only need this to happen to you once to realize how important it is. And finally, suction. This is often overlooked. Make sure you've got a suction apparatus or walled suction, and that with it you've got a Yankauer, so a hard suction nozzle. If the patient vomits or regurgitates while you're trying to intubate, there is no substitute for suction. You can't clear it without it. And anybody who's been in a room where there isn't available suction will know the panic that you feel when these things aren't there. So know your theatre, know what equipment is supposed to be there, but always check you've got oxygen and ambubag and suction. Now, be honest, how much attention do you pay to the anesthetic machine? This machine needs to be checked on a regular basis. Much like you'd want the pilot to check an airplane that you're on. Now, I don't expect a full machine check between every patient. No one does that. It should be checked daily in busy theatres. And in something like a rural setting, I would think that once a week you should be checking this machine. But between every case, there's a check that I do, and you must learn to do this every single case. So I check that the machine's on, and I check that it's on the mains power, not the battery power. If it's on battery power, you've got 45 minutes, and then it's going to switch itself off, and then you need that ambubag and that oxygen cylinder that I was mentioning. So always check that the power is working, especially in rural hospitals where power may be less reliable. Second thing that I suggest you do, sorry for the fuzzy picture, but this person, you notice with their left hand they're occluding the breathing circuit, and with the right hand they're squeezing the bag. So in every patient I do this, and I make sure I can generate a pressure. This is testing a lot of things. With that hand occluding, it's testing that there's gas flowing through the circuit, which is obviously required. It tells you that there is a circuit and that the circuit doesn't have holes in the circuit. Big holes, you won't be able to generate a pressure. It tells you the bag's functional. If you've got all of those things, you can bag a patient even if the ventilator fails. It allows you to know the difference between manual and spontaneous ventilation, because you can't do this without being able to put someone over onto manual ventilation. And to do that, you have to close the APL valve. The APL valve looks different in every machine. On the left is the Drager one. well, in fact, they're both Drager machines. One is a Julian and one is a Primus. And you need to turn that APL valve closed, and there it's been closed to 30, and that's how you'll generate the pressure. With the other one, you wind it down to generate that pressure. So when you're on spontaneous, that should be open. When you're bagging the patient, it needs to be closed to the pressure that you require. And this check that I'm suggesting, closing the breathing circuit, generating some pressure in the bag, you should do it before you start every single time. So just before I give the drugs, I occlude the breathing circuit and I press the bag. The anesthetic machine check, if you want to do the full one, the diploma of anesthetic version, and it is worth watching one of these to get an idea of what's required. This is a video, it's 12 minutes long. That's Dr. Garth Horston, a super keen, very good teacher, consultant anesthetist in Pietermaritzburg. He'll take you through a full machine check. You can watch it in 12 minutes. There's also, in that document that I mentioned, there is a checklist that you can go through if you prefer the written form. It's just helpful for someone to show you how to do this the first time. While we're on the subject of talks, this is the District Anesthesia Education channel where all the talks that I give and a number of other videos that I've collected, I've stuck on this channel. There are two playlists there. One is the ESMO-E playlist, which has the lectures for the document that I've been talking about, and they are given by the people that wrote the chapters within the ESMO-E. So there's 7 different people giving lectures, and they'll take you through the guidelines on how to do all of these things, but with obstetric surgery in mind. So that's the channel called the PMB Way, the Pietermaritzburg Way, and it's got a number of nice resources. There's videos on how to draw up your emergency drugs, a little introduction to the way we do things, the airway trolley check, the anesthetic machine check. There's one there by Andrew Levy at the bottom, looking at a mnemonic way of giving a basic general anesthetic. If you're one of those people that likes sort of acronyms or mnemonics to help you remember everything, that's a 13-minute video or 14-minute video that'll take you through that. So check out these resources, and when you're thinking, oh, I'm not sure if I know how to check the airway trolley, just get out the video. It's 5 minutes. It'll take you through the 5 or 6 plastics and 6 metals when you're checking. The drugs, again, you don't need to remember these doses. You can't be expected to in the beginning. So display these or have them available to you in some way. And you'll notice that we've drawn them up into the red drugs, which are the ones you should draw up every time for a cesarean section. The orange drugs, things like adrenaline, where you don't have to draw them up in advance in every single case, but you should have available and you should know how to dilute them. So go through this list. At the top there, I just really want to stress, if you're doing a cesarean section under spinal, you have to have either ephedrine or phenylephrine drawn up in every single case, because in 70 to 80% of them you'll be giving some of that, and you can't delay. Delay in treating spinal hypertension is one of the major killers in South Africa. And then if you prefer videos, there's a short video on how to draw up emergency drugs for any basic general anesthetic. I've also tried to put some shorts on for you. So if you go to that same channel and you look at shorts, there's 4 there. If you want to know how to calculate a local anesthetic dose, or how to dilute adrenaline for local anesthetic, how to put phenylephrine infusions into the bags that you're running, or how to dilute phenylephrine for boluses. Each of these are maximum 1 minute, and I'll take you through it. And if anybody wants anything else done, let me know, and I'll make them. The airway trolley, you must know how to set this up. You need a working laryngoscope, you need different size endotracheal tubes, Guedel airways, and in particular you need a supraglottic airway device like an Alamay or a ProSeal or an iGel. Usually a size 3 is a good one to have on the trolley, and you must check this. And I think we start sometimes without checking these things. When things go wrong or you need to do an airway, you need this thing checked before you start. So get into good habits, be pedantic about this. You'll notice there's 2 laryngoscopes on this trolley. That's because they often fail, so you want the backup, and it's absolutely standard. And then again, go and watch the video for the details. Now this is the basic outline I'm going to use when I'm teaching about the specific anesthetics, and I'm going to go through this in just about every talk. You need to prepare as well as you can before the drugs are given. And often the preparation is what saves you. just before you put the anesthetic drugs in, just stop and think and have a little pause and make sure you're doing the right thing and that everything's ready. Do the basics right. Expect common complications. So for instance, in a cesarean section under spinal anesthetic, you should expect that there's going to be hypotension and you should prepare for it. So if the patient becomes hypotensive, you know you've got your fluids ready, you've got your vasopressor ready to administer. So these things you get used to, you should prepare for them. Value the recovery period, so don't rush patients out of theatre. They go to a nice monitored setting for half an hour to an hour. You use that period to get a feel for how stable your patient is. And remember to phone a friend. I'm going to come back to this, but you must have people you can contact that you can ask for advice while things are happening. As soon as there's a bit of stability and you can use your phone, phone friends for advice. Now, I've talked about knowing your theatre. The second really basic principle is to examine your patients and link to that to use your monitors. Now, district hospital medicine is often rushed and you've often got a lot of patients. So you'll go to a clinic and there'll be 60 and you're forced to rush a little bit. You can't afford to do that in anesthetics. You have to stop and take your time. It's a very, very different approach. So every patient, heart sounds, airway, look at for pallor and at the hemoglobin. Now, one of the things I want you specifically to look out for is hypovolemia. Hypovolemia and anesthesia don't mix well. So if you put a spinal anesthetic into a hypovolemic patient, the blood pressure is going to fall catastrophically. If you give a normal dose of induction agent in a general anesthetic, the same will happen. So you have to diagnose and correct hypovolemia if you can before you start. If you don't have time, so the patient's actively bleeding, then you need to adjust your whole anesthetic around that. You have to give far less anesthetic, and I'll discuss that when we talk about ectopic pregnancies and ruptured ectopic pregnancies. The second examination area you must look at very closely is the heart rate, and your answer about the heart rate influences the technique you choose and the action you take. So respect high heart rates. When you see those high heart rates, stop and pause. And you must have a theory as to why that heart rate is high. One of them is if the blood pressure is high as well, perhaps the patient's anxious or in pain, and usually when the heart rate's high and the blood pressure is high, that is slightly reassuring. But if the blood pressure is low, or even if it's normal, be wary. That's a compensatory response. Something's going on. And often it means that when you put the patient to sleep, the blood pressure is going to disappear. So always look at the heart rate and respond to it. And the final area of examination that I want you to try and get into the habit of doing is examining airways. Now in the beginning, you may not remember all the different ways. We evaluate an airway in terms of the ability to do mask ventilation and the ability to do laryngoscopy. And I'm going to give a separate talk just on airway evaluation and on intubation and insertion of supraglottic airway devices. But get into the habit of always examining the airway at the very least. Look at the teeth, look at the chin, look at the thyromental distance. And again, you can watch a video to take you through that. Now in this document, there's also a one-page summary of what to do for a spinal anesthetic and a one-page summary of what to do for a general anesthetic. And it's really nice because it just takes you through, this is how often you cycle the blood pressure cuff, this is what monitors you need, this is how you give your fluids, those sorts of things. And it's a very nice checklist. If you've done an anesthetic, go back and have a look at this and read through it, see if you missed anything, and use it as an opportunity to learn. And so some of the things that I think are so relevant from this: assess the fluid status, have good IV access, give a preload of 500 mils, cycle your blood pressure at 1 minute intervals in Caesars, 40% oxygen by face mask for spinals, then give the other 500 mils once your spinal has gone in. That's called co-loading. Get your spinal dose right, which I'm going to show you now. Put a wedge in all patients. Check the block before you start and get your oxytocin dose right. And all of those things are in there. One of the things I want to draw your attention to is that if you're in the Gauteng, the Western Cape, the Free State, or now in KwaZulu-Natal, the dose is changing in the spinal from a total dose of 2.0. So the hyperbaric bupivacaine used to be 1.8 mils. We're moving that to 2 mils for a total of 2.2 mils volume for the standard Caesar. Remember that in short patients this would be less, and there are a whole lot of formula for working out the exact dose. But basically the previous dose we were having too much pain during cesarean section, and so we've increased this to 2 mils, which is 10 milligrams. And just remember that internationally this is still an ultra low spinal dose. So in the UK they give 2.5 mils of bupivacaine plus 0.3 of the opioid. So we actually give a very low dose spinal, and I'm going to give a talk also on high spinals and how to avoid them. But this is the correct dose now for those provinces that I mentioned. And once you put the spinal in, you walk alongside the side of the bed and you make sure that bed is horizontal so the patient's not head down. And that's probably the most important way to avoiding spinal anesthetic, high spinal. All right, the last step is recovery. This is a recovery from one of the district hospitals in KZN. An absolutely beautiful recovery. Don't rush it. So put the patient here and use the time to make your notes beautiful while you wait. That's a good pause to write everything into your anesthetic record. It's so key if there are medical legal things to have good documentations, and then your patient's in a monitored setting, and make sure that before you sign that patient out they're well, and if they're not well that you're scheduling post-op visits. So we've got things like this. This is for the post-cesarean sections spinal patient. One of the things I think you should really do well when you sign these patients out is look at the heart rate and make sure the heart rate's not above the systolic blood pressure. It's always a warning sign. So use that recovery well. Finally, I just want to mention that if you want to go and jump ahead and look at how you do a ruptured ectopic pregnancy, we wrote this article for South African Family Practice a few years ago, and one of the things that's useful in this article is we've put up an algorithm for how to do an unstable patient. And that algorithm in that article, you can again, you can laminate it, stick it on the wall, and it'll take you through induction, maintenance, and emergence, the key steps and recipes to use in the unstable GA. This recipe would work for cesarean section, for laparotomy, for ruptured ectopic pregnancy. It's about as simple as we can make it, and the key thing is you're doing the same thing every time. You're not thinking of a new anesthetic each time. And I would advise learn one technique, get good at it, and then slowly start to look at variations in your anesthetic technique. So this article also contains things on how to draw up adrenaline. 200 ml bag, there's a recipe there. If you've only got a liter bag, another recipe. And this is really to help those people in district hospitals where they don't have syringe drivers necessarily. So there's that sort of practical, pragmatic advice in this article that is worth checking out if you're in an area that doesn't have the right equipment. And then I can't stress enough that you need to get a hold of people that will provide you with expert advice when you're in difficult situations. So make sure you develop a relationship with anesthetic departments, ideally in your referral center, because they are going to be taking the patient potentially. But if you don't have an anesthetic department that you refer to, then find someone that is prepared to help you. Often different centers are quite happy to give telephonic advice. I certainly am if you manage to get hold of me. But it's absolutely key that you know someone who can give you advice when you're a beginner anesthetist. And that's all. I hope that's been helpful, and please let me know if you've got topics or areas that you'd like me to cover. In a month's time we'll start on getting into the granular detail about specific anesthetics. Thank you.